Oh. So that's the answer. Yeah. I'm like, watch my yellow. Her kids are adorable. Okay. That's all I need. I need other friends, cute kids. Or these good nephews. Yep. I'd be too busy for kids. I feel so bad, but Dad, are you this? No, I'm busy. Dad, why don't you love me?
Yeah.
But I'm at work. No, I could never. I feel terrible.
Yeah. That's not for me for sure.
No. I plan to hysterectomy pretty soon. Transition purposes and also, I don't eat your twin. I have a lot of medication.
Yeah.
And it causes, like, that's part of Ehlers-Danlos syndrome, it's intersections.
Yeah. Yeah.
And it causes a lot of internal pain. I'm just gonna get scooped out.
Yeah. It's probably the best bet.
And Mom was like, what do you want hands? Not happening,
If
Mom.
I could get insurance to pay for it, I would, but can't afford it.
If you have recorded, here's an insurance hack I learned. If you have, go to a gynecologist and recorded intense menstrual pain, you can get it. If you've been on Depo for at least 4 years,
Yeah.
they will cover a hysterectomy.
Yeah.
So I've been on Depo since I was 16.
Yeah.
Get that bottle.
Yeah. Yeah.
She's like, why do you want to build?
Yeah.
No reason. But yeah, get on Depo, be on it for around 4 years, you'll pay, insurance will cover your hysterectomy.
Yeah.
Because the uterine lining will be too weak.
Yeah.
Non-oncology.
Well, and I imagine like too, I've had Mirena IUD for, I don't even know, I'm like 10 years now. I've had
Your lining is just.
yeah, that's what I'm saying, is like, I haven't had a period in any of that time, ever,
Yeah.
like
Your
10
lining
years.
is just.
So I can't imagine that.
So yeah, keep that up for like 2 years and then get a, uteroscopy. And you should be able to qualify.
Yeah.
And you can go to New Jersey with your insurance.
Yeah.
And they'll take it.
Yeah.
Because it's part of their gender care act. So I'm gonna go up there and get it
Yeah.
during the summer, not this summer. But I got.
Well, yeah. All right, guys, we're gonna get going with our Kahoot here in just a second. I am in the process of grading the rest of the lab, whatever they were, lab unknown reports. And so those should be graded at the latest by the end of the day tomorrow. So those grades should be posted by then. One thing that I want to mention, I was by far more lenient grading these than I have ever been in any previous semester, because you guys are unable to follow directions and I couldn't give bad scores to everybody. And so it gotten to the point where I've had not everybody, I will say this, not everybody. There were quite a few people that like clearly like followed the directions and put in good effort to it and everything. But there were so many people that just described the motility test for SIM, when I specifically said multiple times, if you do SIM, you have to do all of the tests for SIM. But I mean, there were enough people where I was like, good God, like we're not listening. Okay. And then how many people decided to describe the urea test? When I said in the announcement specifically, do not use the urea test. So either people did, they just described motility or they described the urea test. But I'll give this to the people that decided to describe motility for the SIM test, is that some of the people that decided to do that gave in more description of like flagella and what it is and what it means than a lot of people did on their other descriptions of their other tests that were allowed. I'm just like, wow, so we're not like, okay. So I was looking at those lab reports. It's the worst lab reports that I've ever seen in any of my semesters by far overall, not for everybody, overall. Because people weren't following the directions, especially when it said in the directions to follow the rules of binomial nomenclature. And I had mentioned you can't italicize in that form, but we should have at least followed the rule of the second word should be lowercase. And I can't tell you how many people I had to correct on that. So, and it's fine, but those directions were outlined in the assignment. And it did have an announcement saying, do not give me a description of the urea test. And I said multiple times in the lab, don't do SIM or TSIA unless you're going to describe the whole test. And so there's so many people, I'm going to say at least half of all of my sections was one of those categories. So I was very lenient on it. I didn't give points off necessarily for that stuff. I actually let it slide because I didn't want to have it affect people's grades negatively, because it was meant to be a buffer, right? It was meant to be a buffer. But don't be surprised if you turned in your assignment and I didn't give you feedback. If you got your stuff in for feedback, you got it submitted before Saturday at midnight, and I gave you feedback on changes you needed to make, then most likely, if you got that done, almost all of those people are going to get 100 points out of 100%, almost, because everybody's making their edits and uploading the changes that I made. I told them exactly what they needed to do on those changes. So if you didn't get that in, don't be surprised when you get counted off for capitalizing your second word in your binomial nomenclature. Don't be surprised for that. Don't be surprised if you left your TSIA results blank, which like a lot of people did that too. And don't be surprised when you get points off for not giving your full explanation of the tests and everything, what the positive looks like, what the negative looks like, and all of that stuff in your explanations, because that's the places where people are getting the most points off there. Now, you're probably still getting A, but don't be surprised when you get points off of that stuff, because I caught that stuff on people that did submit early enough. So I'm trying to get those graded. That doesn't mean you can't get 100%. You still can. There's still other people that are. But just be aware of that. You had the opportunity to get that in early enough to get feedback from me. Okay, so just having said that, keep that in mind. If you're like a Unit 4 project person, I'm not going to remind you about what the assignment says on it. It's your responsibility to know what you have to do for those assignments. I'm not reminding this anymore. And then in the future semesters, I'm not going to be doing this hand holding again. Because I feel like it says it in the assignment, or it says it in the announcement, or I said it to you. I'm not going to be doing that again. You know, I feel like if I said a thing, you guys should be responsible enough to listen to it. And so that was very frustrating for me in looking over these lab things. Having said that, people that did describe the urea tests, that did end up doing that, they didn't use my wording, and they were most of the time also missing things on it. So they clearly were trying to do it on their own. They just weren't paying attention to the announcement or whatever. And that's whatever. So yeah, read your announcements. If I post an announcement, read it and make sure that you're following those rules. Not that I'm going to do something like that on purpose, like have a assignment, like announcement that says wear purple to the test or you get a 0 or something. I'm not going to do that, but that would be petty. But just keep in mind that, you know, it's you guys' responsibility to keep up with the things that I'm telling you to do, either in the assignments or in class or whatever. And I shouldn't have to say it multiple times or have you then go on and do it whenever you're doing the assignment. That was very frustrating for me. Certainly, if my nurse were told to do a thing and then they didn't listen to the charge nurse and they did it wrong with me as a patient, I would be pissed. So follow the rules, make a habit of that, and listening to the instructions that you're given. Okay, so whether you're a Unit 4 person and you've still got a project coming up, or if we got a test and it says, you know, put your phone like this or do this with your book bag, or if we have the lab exam coming up, right? Lab exam is on Wednesday. So be sure that, you know, you're wearing your lab coat and your closed-toed shoes. I'm not going to say it again. So if you show up to the lab and you're not following the safety rules for just being in the lab, you're going to get 5 points off. And that's in my announcements too, right? So it's like I'm reiterating a thing that you should already know, but just, I don't want to have you guys be like, oh, I didn't know that. Yeah. So at this late in the semester, I feel like there's no excuse for it. So we get that out of the way. We're going to go ahead and start with our Kahoot for today. We're going to be reviewing chapter 21, and then we are with our Kahoot, and then we are going to jump into the chapter 22 lecture. Chapter 22 is going to be talking about diseases of the respiratory system. All right. All right, what does the normal biota of the cardiovascular and lymph systems consist of? All righty. The normal biota of the cardiovascular and lymphatic systems, you should have no biota in this, just like the central nervous system. These are closed systems that should be sterile of microbes. One thing that I just remembered too, the assignment for the extra credit for the course evaluation, it had opened up today. I closed it again because we haven't gotten out the emails for the course evaluations. But I got like 3 emails this morning being like, I can't find the course evaluations in the assignment. Okay, I've already explained where that is and I'm not going to explain it again. Okay, that's it. Like I can't believe, like, we had this discussion. When we have the course evaluations coming out, where are your evaluation links going to be? In your email. Thank you. Not in the assignment. So I had students opening assignments like, I can't find it in here. This is what I'm talking about, right? This is what I'm talking about. That is very frustrating for me that I have explained this already. And then it comes down to it. And it's just like, I am not here to hold your hand through a thing that I've already explained to you with that. And so this is just, let's not do that anymore. And just, pay attention to what your professor has said to you. And so I said it to you guys. It wasn't anybody in this class, to be clear. Nobody in this class emailed me. But it's just like, just fair warning. When that does open up again, don't be asking me where to find the link. Yes?
Email.
Yes, email. Thank you. You can ask you can ask, I say colleagues, ask your peers, whatever, but like, and it even says it in the assignment too. So I was just like, what do you mean? All right, which term refers to when bacteria are flourishing in the bloodstream? They're flourishing, they're growing, they're actually multiplying in the bloodstream. All right, this is septicemia. So bacteremia is if there are any bacteria in the bloodstream, but if they're flourishing, that's like a next level thing. If they're actually growing in the bloodstream, that is septicemia. So if bacteria are in the bloodstream at all, yes, that's bacteremia. But when they are flourishing in there, then that takes it to the next term, which is septicemia. Because that can cause septic shock, but also with bacteremia, they can just be transient. Like your immune system might just be clearing it out and it might not actually be a true infection at that point. So the difference there to note is the flourishing and growing in the bloodstream. All righty, question 3. Which diseases are associated with infection with Yersinia pestis? And questions like this will be common for the Unit 4 part of the final. They won't all be critical thinking questions. They won't all be meta questions. There will be some questions that are basic. So Yersinia pestis. So Yersinia pestis is definitely the plague, and there's 3 forms of the plague: the bubonic plague, the pneumonic plague, and the septicemic plague, which is also known as the Black Death. Impetigo, I'm glad nobody chose that one. Anybody know what causes impetigo? Staphylococcus aureus or Streptococcus pyogenes for impetigo. Skin infection, yeah? How is Yersinia pestis transmitted? Typically.
That was quick.
Yeah, I hate it too. I know. All right, so Yersinia pestis, the plague is transmitted by fleas. Flea vectors are transmitting them. Pneumonic plague can be transmitted from person to person via aerosols and things like that. But basically, the initial introduction into the human population had to come from a flea vector in order for that to happen. All righty, excellent. What is a bubo? Alrighty, so a bubo is specifically whenever the lymph nodes become infected and therefore inflamed from the infection inside of the bubo will actually become pus-filled as a result of that infection. So inflammation that we usually have with our lymph nodes anytime that you normally are sick, like with the flu or something, that inflammation is that you're swelling up of your lymph node and the soreness of it, that's just from your immune system like multiplying in the lymph node. But when you have an actual infection in the lymphatic tissue, that's going to create a bubo. All right, Epstein-Barr virus is a herpes virus, which causes infectious mononucleosis. Is all of that true, or is maybe part of it false? In order for the whole thing to be true, would I select true for this one? All righty, so this is true. Epstein-Barr virus is a herpes virus, and it does cause infectious mononucleosis. Everything about this statement is true. All right, next question. Question number 7. What type of pathogen causes malaria? Alrighty, so malaria is caused by a protozoa. It's a non-motile protozoa called an apicomplexan. And the name of the organism that causes malaria is Plasmodium. The malaria protozoa live inside of the blood cells or in the liver tissue. It's part of their life cycle. All right, next question. What constitutes a hemorrhagic fever? What happens in a hemorrhagic fever? So you know this is a picture of the Ebola virus. It's just one virus particle. All right, so hemorrhagic fevers are defined by the fact that there is a fever associated with them, an actual raise in the body temperature, and the fact that there is vascular fragility. So your blood vessels will be more likely to break open and then leak into the tissues. That is called hemorrhaging. And so that is what is defining the fact that it is a hemorrhagic fever. I mean, it tells you in the name what the major symptoms are going to be associated with that. So they are not associated with bacterial infections. Typically, can a bacteria potentially cause a hemorrhagic fever? Maybe, but more often than not, hemorrhagic fevers are caused by viruses. And so it's not characterized by it being caused by bacteria. Actually, most of them are caused by viruses. In fact, when we talk about dengue fever, yellow fever, and chikungunya, those are arboviruses. Those are viruses that are transmitted by biting insects, mosquitoes. Ebola and Lassa fever, the other two that we talked about in the hemorrhagic fevers, those guys are not transmitted by insects, but actually maintaining animal populations. So they're zoonoses, zoonotic diseases. All right, next question. Which vector transmits the etiological agent which causes Chagas disease? Literally saw one of these outside on my patio after lecturing about this.
Really?
Yeah.
Did you smash it?
No, I didn't. I actually I told my husband I don't kill the bugs. It creeps me out just to kill them. The crunching of it, like I do the icky like that sort of thing. So I told my husband to kill it. So this is the kissing bug, also known as the triatamine bug. I was just hanging out on my back window to my backyard. All right, which enzyme works to make a DNA copy of its HIV's RNA genome? What enzyme is responsible for taking its RNA genome and turning it into DNA? All right, so the name of this enzyme is reverse transcriptase. Remember, transcription is when DNA goes to RNA. So the reverse of that process, reverse transcription, is done by the enzyme reverse transcriptase. The other ones on here, so integrase and protease. Integrase integrates that DNA that we just made from the reverse transcription. It integrates it into the DNA. It's when it actually incorporates it in there. Protease is an enzyme that HIV uses. Like it makes its protein in a big, long amino acid sequence, and it's all of its proteins in one sequence. and protease clips it into the individual proteins afterwards. And then reverse polymerase was just to throw you guys off and make sure you're paying attention to the terms. All righty, look at our podiums. All right, great job, guys. If you guys haven't been paying attention to, with our 10-question Kahoot, the total possible points you can get would be 10,000. So these are actual, like you could equate this to a percentage of what you're getting on these. I don't know if you guys have been paying attention to that, but so that you guys know how that is. Just FYI. Put it in perspective. People do worse on these reviews of our lectures that we've already lectured over than they do on the lab quizzes. By far. Like, definitely. All right, leave. I made a point about that in one of my other classes, which was just to say, like, we've already lectured over this stuff, and we come back and have the quiz the next lecture period that we have. And people do worse on these than they do on the lab quizzes, and they're all open note. Yeah. So I don't know, there's no points associated with this one. And so I guess like we're just doing it to get the credit for showing up, and that's fine, but use it as an opportunity to test your knowledge about that stuff and look through your notes and associate yourself with that. These Kahoots, by the way, are always open for you guys to go back and retake for your study purposes. They are posted in your Canvases. So if you wanted to go back to that, just reminding you guys of your study resources. A lot of people, I had some students want to have meetings with me about like, hey, how can I start prepping for the final exam now that some of us might have to play a little bit of catch up with units 1 and 2 or whatever. So here is something that I'm going to share with you guys. For whenever you're going back to your chapters, I would start with the chapters that you know that you sucked on, like just be honest with yourself about it, not based on what I would say, but what you would say. Hey, I didn't do great on these topics. Go start with those chapters, right? The ones, and I would rate, maybe look at all your chapters and maybe rate them 1 through 5. 1 is I definitely sucked and I don't know this one. And 5 is I know this content for sure, right? So you can do it with the chapters or the topics in general, or like go through your study sheets and just like rank all of the topics in your study sheets and whatever. The things that you rate 1 or 2, whatever your lowest scoring ones are, focus on studying that stuff first. I'm going to tell you how to study it in just a minute, okay? Focus on studying that stuff first. Then after that, you will go to the ones that you rank 3 or 4, whatever. But I would focus on studying the ones that you definitely suck on. You rate a 1 or 2 first, okay? And then if you have time, then come back to the 3s and the 4s, and then maybe the 5s just to refresh yourself, right? Here's what I would do. I would come to these notes, these lecture slides that we have here, and your study sheet or your notes, right? But you definitely want to go from the study sheet that I had for you guys for each unit, because that is what I'm going to test you on, is those topics, right? So we'll take that and your notes or the slides or all of it, whatever you want to do, and then reorganize the content in those as best as you can. And what do I mean by reorganizing? Let's see if I have something on here, because I'm not going to guarantee that I have it on here. I wasn't prepared for actually giving this explanation. Let's see if I have it on here, because I want to show you guys. Maybe it's in here. No, it is not. Well, kind of. Okay. So when I did this last semester, I made notes of how I would make my notes for one of my chapters. And so this is me saying like, okay, here's the slides. And then I did some highlighting on it, keep track of terms. And then this, I started making notes on the notes. This is me taking my notes. And I said, let's take notes together. So for this chapter, I took all of this content and walked through people how I would create my notes for this content. And this is what my note sheet looked like at the end. So we have this stuff about halogens and phenols and oxidizing agents and all this stuff down here that I took my notes and reorganized that content into a different thing. Now it doesn't have to look like this, but guaranteed, just making a study sheet like this, like the ones that we have for the lab, that sort of stuff, making a study sheet like this, just making one for each of your chapters. And again, start with the ones you know you suck at first, right? Because we don't have a ton of time left, just a couple of weeks now, right? So I would start with the ones you know you suck at, and then create little study sheets. They don't have to be outlined like this. You could have like sections about different topics or whatever. I wish I had more of them on here so I could show you guys, but that this stuff is basically reorganizing your notes and rewriting it in your own words or summarizing the definitions or whatever. That's going to help you learn more than flashcards, listening to my lectures, and whatever BS that you think you're doing to help yourself learn. Guaranteed you're wasting your time studying. Guaranteed you're wasting your time studying with what you've been doing. Take the notes and reorganize them, and then doing that might take some time and some effort, but guaranteed it's better than re-listening to my lectures over and over and over and over again, or reading through the slides over and over again, or rewriting your notes over and over again. Reorganize them and rewrite them, yes, but not copy them. Do not copy. Rewrite it in your own words, and that doing that will force you to think through the process in summarizing these things. Do that for do this first for all the chapters you suck at, and then gradually build up to the ones that you don't suck as much with. And then when you go back to study for the final, just review the content that's on there. You probably don't have to do much else other than that. You want to make flashcards for the terms? That's fine. Don't let me stop you. For new terms that might be more difficult, that sort of stuff. Go ahead and make the flashcards and study that stuff. But don't kill the flashcards. Don't waste your time going over and over and over and over and over and over. If you've gone through the flashcards 3 times, you're done with them. You're done with them. You're done. You're not doing anything for yourself by wasting your time listening to lectures over and over again, especially if you're not taking the time to prove that you understood them. If you can repeat back the content to me and explain it to me, then you understood it. But if you're just sitting there listening to it, and then I go up to you and I say, okay, explain to me why a gram-positive survives better on the skin than a gram-negative. That wasn't in the lectures, but if you didn't get the understanding from the lectures, then you might not be able to say to me, oh, well, that thicker cell wall helps with the osmotic pressure associated with the salt that's on the skin. You see what I'm saying with this? All right, so go through your slides or your notes or whatever you have, summarize them in your own study sheet. I say, if you're doing it on paper, one back and front of a page. If you're doing it on GoodNotes, you can fit it all on one page, guaranteed. So I would put it all on one page or one back and front of a page for each chapter. That way you just have 25 pages to study at the end. You don't have all of these notes from all of these lectures, 60 pages for every freaking chapter or whatever. Yeah, you do that. And I guarantee just making those study sheets will help you more than listening to my lectures over and over and over again. If you don't understand what I'm saying, it's not going to help you. And so this is to basically get you summarize this stuff and get you guys reorganizing that content in a way that makes a little bit more sense. I don't know, I wish I had saved them on here. I have them on my cloud. And so that's the only thing that kind of sucks about this, is that I wish I could have shown you guys the stuff that I made for some of the other content, so you could get what I was saying with it, but I don't think I saved it on my USB drive. That's okay. It is what it is, right? Let's see if I can find it really quick. Audio shorts, lecture slides. Maybe it's in this. No. I just want to see if I have it really quick. And I'm not going to post it for you guys online because I want you guys to make your own. Like, that's the point of it, is making your own. Because if I post it for you and I just give it to you, you guys aren't going to get it. So I just want you guys to be aware that there is stuff you could be doing differently because you're probably not doing it the way that you could be. I don't have it on here. It is what it is. So that's fine. But going through this lecture content, summarizing each chapter for like 1 page of summary, going over the chapters, y'all going to tell me that you're great with your genetic stuff. Definitely probably chapter 6 and 8, you probably need to go over. Yeah, 6 and 8, that's your genetic stuff. You probably need to go over chapter 10, which is your metabolism and your aerobic respiration. And then chapters 15, 16, and maybe 17, depending on that for your immunology stuff. So that's where I would start. It was me. All right, let's move on. Respiratory tract. And then if you guys can go through that, so that I feel like the next best thing you can do is make those sheets. But if you want to actually like take it a step further and prove that you understand the stuff, explain your sheets to somebody. Take your study sheets that you made from the chapters and explain them to somebody. And I don't care if it's an actual person or your imaginary friend sitting in the car next to you, or your pet or whatever. Like I said, explaining it and verbalizing that stuff, having to put it into sentences that are like you can understand the words coming out of your mouth, that gets to you thinking about the material in a way that it has to make sense how you're describing it. It's proven. Multiple studies have shown that forcing you to verbalize it and state it as a statement is more useful than reviewing the lectures or anything else. There's nothing else you can do that's better for you than the verbalizing thing. Just guarantee it. You feel stupid doing it, and I don't care. You want to do well on the test? Do it. Yeah. Take the time. All right, let's do this. This is it. You get 2 weeks, you know, and most people are gonna, the averages on my final around people who are using the study guides to cheat on my tests was about a 75%. So bank on it being lower. Yeah. So bank on it being what you got on your unit 3 exam, unless you do something different. And we're talking something that is worth 12% of your grade. So if you want to risk that, that's on you. I'm telling you, if you want to do better than that, then you can. There's stuff you can do. Are you doing it? Probably not. Are you probably wasting your time listening to my lectures over again, or doing Kahoots or Quizlets and not actually taking the time to understand why the right answers are right or the wrong answers are wrong? You're just doing them and say, oh, this was the answer. Why is that the answer? So, and if you're like, oh, I don't need to know why, good luck. Good luck with that. Okay. So this is me. This is it, man. It is crunch time. It is time to do the things. You've got all those Kahoots that we've gone over. Maybe go back over them and figure out why the right answers are right or wrong. You can use a different email address or a different username to sign into them and retake them again and use those as tools. Use ChatGPT to write you questions, but don't just memorize the answers. Explain why the answers are right. And that's why I gave you guys. So what I would do would be like, make your study sheets, explain your study sheets to somebody, and then go to my comprehensive questions that were open-ended questions that said, explain this or that, or if you step on a nail, then what happens, or that sort of thing. Those open-ended, like more meta questions. Make your study sheets and explain them first. You don't have any business trying to answer those questions if you didn't do that. Seriously. You have no business trying to answer those questions if you didn't take the time to learn the material first. How would you apply it if you didn't even know what was going on with it in the first place? So take the time. Do that stuff. It will be easier on you than rewatching the lectures, than copying back over your notes, or trying to take 1,000 Kahoots over and over again. And whatever stuff that you guys have done in the past, that's repetitive stuff, that has worked for you for other classes that you've already probably learned will not work for you for this class. Okay? All right, upper respiratory tract versus lower respiratory tract. Pretty much everything from the throat up is your upper respiratory tract, and then down is your lower. So we're talking about your throat being called the pharynx. Your actual vocal cords, that vocal box area, is called the larynx. The epiglottis is the little tissue flap that opens and closes the breathing side versus the eating side with your digestive versus your respiratory systems. And so upper respiratory tract versus lower respiratory tract, and again, your lower being your lungs and the aspects of the lungs like your alveoli, your bronchioles, and your bronchi, and all these things that are parts of the lungs and how the air is getting into the lungs and causing the gas exchange within the alveoli of the lungs. Inside of our respiratory tract, we do have a ciliated epithelium, especially in the trachea and the bronchi in our lower respiratory tract. The cilia help move mucus and debris out of the lungs, and that coughing helps with the expulsion of things in the lungs as well. And mucus traps the things, sneezing helps expel things, swallowing helps move things down into the GI system instead of into the respiratory system. All of these are our first line defenses. Second and third line defenses, your complement action in the lungs, increased levels of cytokines and antimicrobial peptides, macrophages in the alveoli that we call alveolar macrophages, and then secretory IgA. Remember, IgA is the one that's found in the mucosa, okay? And that's found in the mucus, so that, IgG is our workhorse, but it's found in your bloodstream. It doesn't get into the tissues. But IgA gets into, like, on the mucus and is involved in the mucosa. So that's going to get protection in those areas. All right, the normal biota of the respiratory tract, we have a large number of microbes that are part of your respiratory tract. Lots of bacteria, yeast, and even protozoa and viruses are normal biome participants in your respiratory tract. So this does have a normal biota associated with it. Yeast, particularly Candida albicans or Candida auris, are pretty common in the respiratory tract. Here are some other guys that are also considered to be normal biota, which can cause disease if they overgrow or move to tissues where they don't belong. So if there's something that's normally in the upper respiratory tract and they move into the lower, or if they move from the respiratory tract into the nervous system, they can cause disease. So this is Streptococcus pyogenes. It's a normal part of the biota. It can exist in small numbers in some people, and they get transmitted to other people that don't have it, or it can grow out of control in the people that do have it. Haemophilus influenzae, Streptococcus pneumoniae, Neisseria meningitidis. All three of these are causes of meningitis, bacterial meningitis that we talk about, and they're normally harbored in your upper respiratory tract. But if they get into the lower respiratory tract, the top two, Haemophilus influenzae and Streptococcus pneumoniae, are commonly associated with pneumonia, and can also move into the nervous system like Neisseria meningitidis can. Staphylococcus aureus, also part of your normal biota, that can cause disease, not just on your skin. This guy also can live in your upper respiratory tract, like in your sinuses and things like that. The overall composition of the lung biome is altered in patients who have lung disorders. This could be either due to something like cystic fibrosis, which is an obvious thing that would be affecting the lungs and the mucus that's being associated with that, but it also could be people who have emphysema or something like that that was they acquired later on in life. And that this could, their biome could have some effect on what diseases they might be more likely to have. So we're moving on to our diseases now. The common cold is our first one. The common cold is considered a syndrome. It's defined by its signs and symptoms. Here we have sneezing, scratchy throat, runny nose. Generally, there's not a true fever associated here. It might be a very low-grade fever in some cases, but it's usually not associated with fever. And you're not going to have that achiness and that fatigue that comes along with the flu. So there is a difference here with those signs and symptoms as well as with the causes. So we also call this rhinitis. And this is going to associate with the nose, potentially also the sinuses and the throat as well. So common colds, there are over 200 different kinds of viruses that can cause the common cold. This includes 99 different rhinoviruses, several different coronaviruses, not COVID or SARS necessarily, but other coronaviruses, adenoviruses, and RSV. It's going to be more serious, actual cause true respiratory distress in younger children, but in adults that get RSV, it presents as a common cold symptom, typically in people who are having normal immune systems. All of these guys are transmitted by droplet transmission. They are airborne. There's no vaccine. There's no chemical like antivirals that we usually give for people because this is normally going to be a self-limiting infection. Your immune system is also going to get rid of it very quickly. So we usually don't treat the common cold. Also, how do you treat something that's caused by 200 different kinds of viruses? I don't know. You don't have, I want to be very clear, you don't have all 200 at once when you have a cold, right? You have one of them when you have a cold, but it can be caused by different things. Next is sinusitis. Usually this is going to be associated with sinusitis, inflammation of the sinus tissue. Usually this will be associated with some sort of like rhinitis first, and then the development of the sinus infection afterwards. This can be caused by allergies or infections. There are 4 pairs of sinuses in the skull, and this could be inflammation or infection in any of those 4 pairs. Signs and symptoms of sinusitis, you have sinus pain, nasal congestion, pressure, headache, even toothache when the pressure is getting pushed onto the nerves of the teeth underneath. Discharge will be opaque and can be yellow or green in color. It's actually more commonly caused by viruses and not by bacteria, but it can lead to secondary infection from bacteria whenever we have progression of the disease. It's usually the same viruses that are going to be causing the common cold. Bacteria is usually going to be only when it's a secondary infection as a result of another viral infection. And again, bacteria more commonly is going to be overgrowth of bacteria that you have in your biome, and it only constitutes about 2% of sinusitis cases. So we're talking like 98% of sinusitis cases are caused by viral infection. So the next time you go to the doctor because you have a sinus infection, they're giving you an antibiotic. No, that's what I'm saying. That's not what treats viruses, right? And so that's what we call with shotgun treatment with antibiotics. Yes.
Sorry, just slides back. But what was all the normal biota stuff?
So
like the overarching, like protozoans.
So bacteria is probably the most common in the biome, but protozoa and viruses and yeast too. Yeast is probably, I'd say bacteria, then yeast, then maybe protozoa and viruses. We didn't talk about any specific ones or anything except the yeasts, which might include Candida albicans.
Right.
Yes. All right, so fungi, you can have fungal sinus infections. It's usually only going to be recognized as a fungal infection whenever the antibiotics or the viruses aren't clearing themselves out, and then steroids and antibiotics aren't fixing the issue. Then we would assume that it would be fungal. Again, this is usually going to be caused by fungi that are in the environment that are getting trapped within, like you had a viral infection or an allergic sinusitis already. And so that inflammation let the fungus come in as a secondary infection, an opportunistic one due to the inflammation in that area. All right, acute otitis media, AKA an ear infection. So this is usually going to be due to, so what's happening here is we have inflammation of the eustachian tube. There's fluid buildup, usually from sinusitis or something like that. And the inflammation causes fluid buildup in the eustachian tube. And then bacteria will be able to grow in the fluid that's built up in there. And then that would cause an increased inflammatory response in the ear. That secreted fluid that is associated with this will be called effusion. And you need to be able to have like fluid be released and pressure be released between the ear and in the throat and the sinus areas. If that inflammation becomes too strong and blocks off basically the fluid being able to move between those two areas, then that pressure will build up in the ear. And then that can be what would necessitate you to have like drainage tubes put in the ear, the tubes in the ear. Yes. Yeah, they're pretty common. They're pretty common. Yeah, and so they can release the pressure with the tubes in the ear, but there's a risk that if you don't have that pressure released, that your eardrums can actually rupture on their own, which can cause a more widespread infection. And then that itself can cause permanent hearing damage because that might not heal up properly afterwards. Yeah.
Okay, that makes a lot of sense. As a kid, I had to get two ears.
Mhm.
After they took them out, it put a hole in my eardrum permanently.
Yeah, that can happen
I
too.
had
Yeah.
to go in there and try to cover it, but it didn't.
So awesome. Yes. So this is one of those things where that eardrum is involved in keeping sort of the barrier between the outside environment and the ear, but it's also important for sending the vibrations to the bones in the ear that's involved in the hearing there, which we won't get into in this class, but damage of that can lead to decreased ability to hear overall, as well as increased susceptibility to ear infections later on in life. And so that's a bigger issue associated with that. Usually otitis media, again, we're gonna have that fluid building up in there, and the bacteria that's normal part of the biome, or the yeast that are normal part of the biome, will overgrow in that fluid buildup. You have a feeling of fullness or pain in the ear. You might have loss of hearing as a result of the pressure buildup, and then the signals, the vibrations can't be sent like normal. Infection can cause the eardrum to burst, so it's better for us to put tubes in to let it to drain, because it's more likely that you'll heal properly from that. Sort of like what we talked about with the skin fasciotomies. It's a similar sort of a thing. So most of the time, most ear infections, we're not necessarily going to be productive with treating it with antibiotics or antifungals. We're usually going to watch and wait for 72 hours, and it should start to alleviate itself. Only then will we start treating it with medication if it doesn't alleviate itself within 72 hours. Then we can use tubes to help with the drainage associated with that, and then maybe treat the appropriate microbe that we think is associated with this. The most common cause of otitis media, of ear infections, is Streptococcus pneumoniae. I said that it was going to show up a lot, and it is going to. So most common cause of ear infections is Streptococcus pneumoniae, the #1 cause of bacterial meningitis as well. And it's also going to be the #1 cause of pneumonia, as it suggests with its name. Also, more commonly now, we're seeing cases caused by Candida auris, which is a yeast. Remember, yeast are fungi, and it's becoming increasingly resistant to antifungal medications. And so this is becoming, like I say, it's more worrying because we have they're commonly resistant to antifungals, and so more difficult to treat. It's not a communicable disease. You don't get it from other people. Yes.
That also like what thrush would be in like a child.
Yes.
So with that being said, would that like make it more
Like
severe, deadly to a child that has it now because of the resistance that is building?
potentially, yes, potentially. If it is responding to treatment with antifungals or something like that, then you're probably still safe. Just be sure that they're following through, the parents are following through, making sure the child is taking all of their antifungals, and not you're saying, oh, it's getting better and stopping. I mean, how many of you potentially, maybe not you, maybe it's your friends or family members that would say that they have, oh yeah, I'm feeling better. So they stop their antibiotics and they save it for like maybe a future infection. How many of you guys know people like that, right? And so don't let that happen, right? And so it might be your parents, it might have been you, but don't let that happen. We have to follow through with all of our medications, whether it's antibiotics or antifungals, to be sure that all of them are eliminated. Otherwise, they'll just grow back and potentially be resistant to it the next time. And then keeping them in your cabinet for future use won't help you because it will be resistant. I'm moving on to pharyngitis. Your pharynx, again, is your throat and all the tissues that are in that part of your throat, not just your tonsils. And so I want to be very clear about this. You might be more likely to have pharyngitis if you have tonsils because you have more tissue there that can be popping more stadium seats, but you still got stadium seats even if you don't have tonsils. So you can still get pharyngitis even without tonsils. So this is inflammation of the throat. It could be due to a lot of things, but in this case, we're talking about infectious reasons. Oftentimes, pharyngitis will be caused by the same viruses that cause a common cold. However, more serious cases are associated with bacterial infections, and this would include Streptococcus pyogenes or Fusobacterium necrophorum. So Streptococcus pyogenes is strep throat when this happens. So it's pharyngitis caused by Streptococcus pyogenes, that is strep throat. All right, so signs and symptoms, inflammatory white packets on the walls of the throat. You'll have a redness of the throat. It'll be visibly irritated. You'll have difficulty swallowing. It will hurt to swallow, and you might have foul breath associated with the bacterial overgrowth in there. When you have a viral sore throat, you usually won't have quite as many of these symptoms, and it won't be quite as severe, but it sometimes might lead to hoarseness of the voice. And the bacterial is significantly worse, and you might have fever associated with this. This is an image of the tonsils and the throat with the white patches on them associated with strep throat. All right, so Streptococcus pyogenes, the main more serious bacterial cause of this, is a gram-positive coccus that grows in chains. It's a facultative anaerobe. It produces a capsule and a slime layer, making it difficult for our white blood cells to eat them up. Untreated streptococcal infections can lead to scarlet fever, rheumatic fever, and glomerulonephritis, which is what we were talking about with the acute post-streptococcal glomerulonephritis from chapter 17, which was the type 3 hypersensitivity, the immune complex ones. All right, so we actually talked about all of these. Rheumatic fever happens whenever our body starts reacting to the bacteria, but the bacteria have molecules on their surface that are similar to ours, and so it causes a temporary autoimmune effect, and so that can cause damage to the tissues of the heart as a result of that, and that's rheumatic fever. Scarlet fever is where we have a rash developing over the body as a result of that strep throat, again, usually associated with the immune response reacting to cells in addition to the bacteria. But it's going to be more temporary. Anybody that's ever had a rash associated with having strep throat, that is scarlet fever. That's what that is. So, well, we're clear about that. More commonly seen in kids. All right, so again, S. pyogenes, Streptococcus pyogenes has antigens on its surface that mimic the host. And so that's what leads to those sort of anti-self reactions from our immune system. And it has certain toxins associated with it that lead to cell injury, cell damage, and damage of the tissue overall, as well as invasion of through the extracellular matrix and all of that, which I'm not going to get into that necessarily. But it has an erythrogenic toxin, so of ability to cause the lysis of the red blood cells, that toxin that it makes, that helps it with invading your tissues and things like that, was actually derived from having a phage infection. So the phage infected the bacteria and then carried with it these genes for these toxins. And now it has these toxins because of that phage, and we call that lysogenic conversion. Yeah. So we call those lysogenic strains, and those are the ones that are associated with scarlet fever. We also have Fusobacterium necrophorum. It's a bacteria that is associated more with like peritonsillar abscesses. And so what happens if you have your tonsils, this bacteria will grow kind of behind the tonsils or in between the space of throat tissue and the tonsils, and cause pockets of pus that can actually rupture and lead to severe sepsis and things like that. So this can actually be deadly. It causes about 15% of acute pharyngitis cases, so it's not as common as what we see with strep throat. Yes.
Are these like out of control tonsil stones?
Not usually. So it's usually a different kind of a thing, but I'm not saying that tonsil stones can't lead to infection in the tonsils. Of course they can if they are left in there for too long from the bacteria that are associated with tonsil stones. So if you guys aren't clear, tonsil stones are little white, they are stone-like because they are like semi-solid, but they fit in the pockets of the tonsils. So tonsils are there to trap debris that's coming in through your ingestion of stuff and your breathing in of stuff. So they trap stuff in the pockets in the tonsils, and then the tonsil is supposed to clear it out, but sometimes those pockets don't get cleared out and we have development of tonsil stones. The tonsil stones do exist largely of your neutrophils as well as the bacteria that got trapped in there. And so if they're left in there for too long, they can potentially lead to the development of infection, though not commonly. Usually you can express those stones and have them be rinsed out. You can either rinse them out by gargling, by using a water pick to like literally rinse out the crypts, which are the pockets in your tonsils, or like you can potentially express them by squeezing the tonsils, so I don't recommend that necessarily because it can cause damage to the tonsil tissue, as well as the bacteria on your hands getting now into the throat where that doesn't belong. And then now your hands having the throat bacteria on them. And yeah, so if you have tonsil stones, that's something to discuss maybe with your dentist or your ENT, if those are a chronic problem for you. And tonsil stones and them being chronic and you having chronic tonsillitis as a result of enlarged tonsils. You guys, I had my tonsils out when I was like, this was 2019, however old I was now, 35 or something. And I was 35 when I had my tonsils out. And my tonsils were so large, they touched when I didn't have an infection. Can you imagine how large they got when I did get throat infections? It was like I couldn't breathe at all. And so I had severe sleep apnea. I mean, I'm overweight and that's a problem too, but like I had severe sleep apnea where I couldn't breathe like at all at night. And so I went to an ENT and he's like, we can use this to make your insurance pay for you to get your tonsils out. And so I had to like sleep with like CPAP for a while, and it had to like show that I was actually having apnea, and we use that as proof for my insurance company to have my tonsils taken out.
I assume that's something you notice if you have them, right?
Yeah, I think so. Mine were so large that it was my tonsils were so big, and like I didn't really have a perception of like what it was to like have large tonsils. You don't really look in other people's throats that often, you know. So yeah, yes.
Is it true that the healing process?
They say that. Mine was not. Yeah. So
You know what stuff worse was the pain medication, because then it'd make me vomit.
yes.
And then
So that's the
vomiting
thing.
really irritated my throat while it was healing.
Yeah, they usually give you like codeine or something like a codeine cough syrup. And that, yeah, and that can make you very nauseous. And so that is like, you're supposed to like let it heal and you get these scabs that form where the tonsil tissue was. And then it's like, once they fall off naturally is whenever you're like fine again. But like, you're supposed to let them fall off naturally.
But
And
it's
like
a
that
wet
process,
scab.
it's a giant scab. Yes. And you can like feel it flaking off in your throat and like all sorts of stuff. So mine, I was extremely lucky, despite having very large tonsils. My tonsils, yeah, and so my tonsils healed very well, and I had very little like issue with it. I would go through it again. Like it was definitely like worth it, yes. And so that was one of those things that like I don't have tonsils anymore, and I'm very thankful for it. And my process of healing went very well. Highly recommend popsicles and things like that during the healing process. And I mean, I have like my own recommendations to say gargling with, you know, isotonic solutions and things like that, or not too salty and not too watery, right? So that can help with that stuff. But I mean, mine went pretty well. I mean, I was in my bed. I was like away from work for like a week because of this recovery process, but like it wasn't bad for me. I don't know.
was so young, I don't remember.
Yeah, yeah.
But my sister had to get the tonsils out and she was young too. I know to go back.
Mm-hmm.
So
That can
they had
happen
to-
too. Yeah.
She had to get
Yeah.
and
Yeah, if you if they don't get all the tissue of the adenoids during that process, then the rest of the tissue that's left will just grow back.
Are you missing anything by having not having tonsils?
So your tonsils are part of your lymph system, and so they help with, like I said, catching like debris and bacteria and things like that that are coming into your GI tract. But it's sort of like with your appendix or your gallbladder, right? You need your gallbladder. Your gallbladder provides bile to your, stores the bile so you can have large influxes of bile when needed during your digestive process. But you can definitely live without a gallbladder, but you're going to have some side effects from that. It's sort of like that with your tonsils. You might be at an increased risk for certain respiratory infections, but if you have an otherwise healthy immune system, you probably won't notice it. Yeah.
when you swallow.
Yes. Yeah.
The only time I ever get sick are cold and sinus infections.
Yeah. So Fusobacterium necroforum is associated with causing abscesses in that tonsillar tissue, and then that could potentially lead to septic disease as a result of that. All right, moving on to whooping cough. This is known also as pertussis. So in your DPT or your Tdap vaccines, whichever version you're being given, we have diphtheria, pertussis, and tetanus. The diphtheria one, we're not going to necessarily talk about in this class, but diphtheria is another respiratory disease that's caused by a bacteria. Pertussis is caused by a bacteria as well. We're going to talk about it in a little bit, but Bordetella pertussis is the bacteria. There's 3 phases when you have pertussis. The first phase is known as the catarrhal phase. This is when you have a basic respiratory symptom stuff going on. Maybe a minor cough, a sore throat, and a fever associated with it. But then we have the paroxysmal phase. In pertussis, in the paroxysmal phase, we have uncontrollable coughing with a whooping sound. This is where you have people like that, like they're coughing so much they can't breathe, and so they have to like take huge influxes of breath. That's the whooping side of the whooping cough, okay? You're coughing so much you can't breathe in. And so that's what happens with this. This can lead to broken blood vessels in the eyes, vomiting, and even hemorrhages in the brain. Not from the bacteria, not from your immune response, but from the coughing from this. We also call this the 100-day cough. This is not a short, week-long infection that you have, but weeks of coughing like that, or straight, like just constantly barely being able to catch your breath kind of coughing. There is also the convalescent phase where the bacteria are decreasing and the coughing is decreasing, but you had so much coughing, it's depleted your cilia in your lungs, and now you're susceptible to secondary infections as a result of that, the damage associated with this. So we're gonna play this little video of this baby that has pertussis. This is still a disease.
Meal. Vanity Fair napkins. Elevate every day.
Oh my
Adjust
gosh.
Formula, a happy.
Guys, it's still a disease that we
Happy
see in the
family.
United States
Learn
in
more.
little babies that haven't been vaccinated yet. It's more common in them.
Feel that, right?
So this is a disease that we see in infants primarily, like whenever somebody has a baby and then maybe the grandparents come and visit and the grandparents haven't been keeping up with their vaccine, and they can carry the bacteria and give it to the baby, and the babies are going to be who present the worst and can die from lack of oxygenation, from hemorrhage in the brain, and all sorts of things associated with this bacterial infection. All right, again, this is a bacteria called Bordetella pertussis. If Bordetella sounds familiar to you, that's because a different kind of Bordetella bacteria is associated with kennel cough, a very similar disease, but in dogs. It is a Bordetella bacteria as well, commonly associated with that. All right, so this is Bordetella pertussis causing pertussis or whooping cough in people. It's a small gram-negative rod. It is aerobic. And all of these other things are associated with it. The pertussis toxin is what the vaccine protects against. And so that toxin is what is associated with the development of these severe symptoms in the paroxysmal phase of the disease. It also has endotoxin because it is gram-negative. And so this would trigger production of cytokines and the complement response and things like that. That can also lead to the inflammation in the lungs associated with the disease. The pertussis vaccine is incredibly effective. You usually are going to get this with your initial vaccine set, and then you'll get another booster after the age of 11 years. And then every time that you get your tetanus vaccine, which you're supposed to be getting every 10 years, then you'll get a booster with this along with that. Moving on to RSV. This is caused by a virus called respiratory syncytial virus. Again, we've talked about syncytia previously when we're talking about viral infections. This is where the cells merge together and create these giant multinucleated cells. This is spread by airborne droplet transmission and things like this. It's going to cause more serious disease in children 6 months of age or younger, premature babies, and people with decreased immune response. In 2020, because we had all of the masking and this just reminded me of a thing that's going to make me angry if I start thinking about it. Okay, moving on. In 2019, when we had COVID come out and we had masking and we had social distancing and things like that, we saw a decrease in our respiratory infections along with that. As a result, we had a decreased amount of flu and a decreased amount of RSV. If you haven't gone to covid.gov, you will notice that our government has just posted a notice about how it was a lie that masking and social distancing helped with the spread of COVID. Please. Anyways.
There's a professor here that said that.
Yeah, well, yes. And so like the thing is, whether or not it may have actually led to the decrease in COVID, it probably did lead to the decrease of the spread of COVID. But what helped the most was the vaccine. And so people are saying, what? Well, the vaccine helped. It wasn't the social distancing. Well, I mean, I don't know that we were doing it for long enough to necessarily say we proved it or not, but it definitely was associated with decreased RSV and influenza. So social distancing was helping with decreasing the spread of respiratory diseases, period, whether it was COVID or not. And so if you had COVID, did you want to get flu or RSV on top of the COVID? Probably not, right? And so like that's the other side of things, is that people weren't just getting COVID, but potentially other diseases as well.
Research COVID.gov now just get loudly with Trump in the middle of it.
I'm just saying, if you haven't gone to covid.gov,
That is what COVID.gov is.
I hate that fucking orange carrot.
we're gonna move on, okay? So I was one of those things, you see the things on Instagram, and you have to take everything on Instagram with a grain of salt. This was one that I took with a grain of salt and went and visited the page, and it was not wrong. Okay, all right.
Unrelated, but for whooping cough, why does it make the eyes bleed?
So it's literally from the cough, like the pressure that builds up in your blood vessels, literally like the fragile blood vessels in your eyes that causes them to rupture just from. Yes. So it's like the pressure that builds up in your vasculature as well as just in your respiratory system. I mean, that's not common, right? We're not going to see that happening to everybody, but yes. All right. So RSV is respiratory syncytial disease. It causes a cold-like symptoms in people with healthy immune systems, but can lead to severe signs and symptoms in younger people or people with immune system issues. Again, more serious RSV will be associated with bronchial tree infections, parenchyma, croup, and difficulty breathing. So this is overall respiratory, like severe symptoms that could land you in a hospital as a result of that, usually associated, like I said, with infants, premature babies, and people with decreased immune function. It is very contagious and is spread through droplet contact as well as through fomites. Moving on to influenza. Influenza is caused by a virus in the Orthomyxoviridae family, which I won't test you on, but it's just a virus of its own. Influenza is, and then it causes the flu, and it's the only cause of the flu. We have flu A, B, or C, and it just depends on its genetic makeup of how it is categorized that way. For the flu, we have annual flu seasons. Every year we have new strains of the flu, and your body sees the new flu strains as entirely new viruses, because to your immune system, it's new antigen, and that's all your immune system cares about.
Because not the B cells, and the T cells are like that. That's not what I'm
Yes.
looking for.
Yes. And so the B cells and T cells that saw the previous year's flu recognize that previous year's flu. It's not that the vaccines aren't effective, it's that they're effective for those antigens. The next year we have new antigens associated with the flu. And the flu are extremely highly mutating viruses, as well as they have this whole other system for viral like antigen exchange that we're going to talk about in a second, called antigenic shift. You have headache, chills, dry cough, body aches, fever, stuffy nose, and sore throat associated with influenza, and then extreme fatigue that can actually last for weeks even after clearing the virus. It leaves patients vulnerable to secondary infections, and the secondary infections are usually what lead to pneumonia. The flu itself can cause pneumonia. Patients with emphysema and cardiopulmonary disease are going to be able to be more at risk for severe infections. Because your body has seen some versions of the flu, you'll have some immune defense against certain parts of the flu. But when we get whole new strains out, like H1N1 or H5N1, or like a big old change in the H's or the N's on those viruses, those are like seeing like COVID versus like the cold virus. Like they're a completely new virus to us. And so the whole reason that COVID was so bad for us is it was a brand new virus that our population had no immunity to whatsoever. And so that was the issue with that. Same thing with new flus, where we have the big shifts in the H's of the N's. They're like a brand new virus to your body. And so little shifts might be, you might be well protected, have less severe flu symptoms. But when we have the big shifts, like we saw with the 1918 flu pandemic and the Spanish flu and things like that, that those are so new to the human population that we had no existing immunity within the population. And so more people were dying from that, even healthy people that were associated with getting that disease. So with the flu virus, the things that we're going to talk about are the hemagglutinin and the neuraminidase, the H and the N. And you'll see here, the flu virus, these are the gene segments in the flu virus. We have 8 different gene segments in there, and that's going to count for something in a little bit, okay? On the surface of the flu virus, we have two glycoproteins, hemagglutinin and neuraminidase. Hemagglutinin is our binding receptor, and the neuraminidase breaks down the mucus as well as helps with entering and exiting the cell whenever we're budding out of a new cell.
And it's an enzyme, right?
Yes. All right. So when we get these different flu viruses, you can have antigenic drift or antigenic shift. If I were going to say that you are drifting through an ocean, you're being moved by the ocean waves, but you're moving very slowly and with the current, right? You're making no effort to shift your position actively. So drifting is something that happens naturally. These are natural small mutations, just natural in like random mutations in the genome. That's antigenic drift. But antigenic shift happens when you have H5N5 in the birds and H1N1 in the pigs. And then the pig that's infected with H1N1 gets infected with H5N5. And now as a result of that, you might have H5N1. And so this is gene reassortment of those 8 segments. When you have a host that's infected with 2 viruses of the flu, that they can reassort those gene segments to create a whole new virus with new gene segments in it. That is antigenic shift. This is what often leads to influenza pandemics. And so we have the duck influenza virus and the human influenza virus infecting a pig. It's able to create a new virus with a new segment in it from the duck, but mostly pig genes, but that this is now a whole new virus to humans. And this can potentially lead to that. So that's antigenic drift versus antigenic shift. And one thing that I tell my students is to remember the difference. So yes, I think of drifting in the ocean. You're just subject to the natural mutations from the environment. But antigenic shift, you are actively, like it's been a major shift in that DNA sequence. But one way that I remember that is with this picture. And one day I said antigenic shit instead of antigenic shift. And I think of pigs being covered in poop a lot. And they're poopy animals, okay? And they're naturally and just like not kept in your house, but when they're kept out in a farm, they're poopy, okay? And so that's how I remember, like, oh, this is the thing that happened whenever we have the different species coming into the poopy pig, is the antigenic shift. So that's how I remembered it. But all right, so drier air. So when people say that, oh, don't go outside or you'll catch a cold. Well, you're not getting sick from the cold air. That's impossible. But what is happening is that your mucous membranes in your lungs and your sinus cavities are getting dried out. And as a result of the dried outness of the cold, dry air, that you're more susceptible to getting infections like the cold and influenza. So you actually are more likely to get sick if you've been in the cold, but it's not from the cold making you sick. It's from the viruses are now more able to infect you because of the cold, dry air, okay? So again, during COVID-19, we also kept up with deaths and infections associated with influenza, and that the masking and social distancing caused a decrease in influenza along with RSV. There are vaccines associated with the flu, but because flu is able to mutate so easily, we have to have new flu vaccines every year based on the new strains that are coming out. We are working on a universal flu vaccine that should protect against all strains of the flu, but those are currently not out for use yet. Moving on to tuberculosis. Tuberculosis is an ancient human disease that has been existing pretty much since humans have existed, from what we can tell. It's a bacterial disease caused by Mycobacterium tuberculosis. So because it's Mycobacterium, we know the bacteria are acid fast, which means that they have mycolic acid on the surface of the bacteria that makes them more resistant to drying and to being killed by cleaning methods. The infectious dose for tuberculosis is 10 bacteria. All you need to be introduced to on average is 10 bacteria from the environment. And these are pretty resistant bacteria, and they can be carried in droplets in the air for hours after somebody leaves a room. So it's a pretty infectious disease. First of all, you have primary tuberculosis. The bacteria will move into your lung tissue and be eaten up by your alveolar macrophages that exist in your alveoli. But they want to be in there. They live in there. So they live inside of the alveolar macrophages. They don't get digested by the phagolysosome, and they're resistant to that. And so they actually are welcoming the white blood cells coming to eat them up. So we have granulomas that form. Your immune system white cells come to try to wall off the infection, and this creates these sorts of, we call them granulomas. And specifically in tuberculosis, they're called tubercles. So they are these giant granulomatous-like encasements of white blood cells and bacteria. Those are the tubercles. And so these can actually become necrotic. And like the cells that are being walled off on the inside, because tuberculosis is an aerobic bacteria, as they're getting walled off, they don't get oxygen, so the bacteria die. The cells that ate them up can die as a result of everything that's going on as well. And so the dead cells then die, and then, you know, bacteria can cut from the natural lung tissue as well as other tuberculous bacteria can cause necrosis in that tissue. And so those can become necrotic caseous lesions. Caseous, like casein, like in cheese, is clotted milk. And so that's really what that's talking about, is like these are semi-solid white cheesy lesions inside of the lung tissue. And then those over time can become calcified as they harden and dry out from exposure to just air from what we breathe. And so that is usually a permanent effect of having had tuberculosis. Even after treatment, you can still see some of these lesions and the damage that they left in the lungs, the scarring in the lungs as a result of that. Primary tuberculosis is whenever you're infected with the tuberculosis bacteria and they're developing these lesions in the lung, but you might not have any signs or symptoms associated with it at first. And then your body will attack it and it will go into remission. Most people, when they have tuberculosis and they have a healthy immune system, you don't have signs or symptoms. But when you get stressed out, or people who don't have a healthy immune system, they will have outbreaks of the secondary tuberculosis, which we'll talk about soon. The PPD test is testing for the body's reactivity to the antigen of tuberculin, which is on the surface of tuberculosis bacteria. Again, this is based on your cytotoxic T cell response because these bacteria live inside of the alveolar macrophages. It's an inside infection. And so your CD8 positive T cells, if they have seen the tuberculosis antigen before, will have a reaction in 48 to 72 hours after exposure to the skin antigen. We'll look in the X-ray and be able to see the damage in the lungs as part of our diagnostic process. Dormant bacteria in the lungs will be reactivated when the immune system wanes, leading to severe symptoms of violent coughing, greenish or bloody sputum, low-grade fever, anorexia and weight loss, fatigue, night sweats, and chest pain. If you get to the reactivation version of tuberculosis, the secondary, and you start having these signs and symptoms, if it is untreated, you're talking about a 60% mortality rate. That is pretty impressive. So again, this is Mycobacterium tuberculosis. That acid-fast aspect means that we have the mycolic acid wax on the outside of the cell walls of these guys, and that makes them resistant to drying and to disinfectants and makes them able to survive the oxygen going in and out of your lungs. They're aerobic bacteria as well. This tuberculosis can also be caused by Mycobacterium avium complex, but this is more commonly seen in AIDS patients. Similar disease, just with a different Mycobacterium species. And again, we can do the acid-fast test and see the fuchsia-colored bacteria staining positive with that carbonyl fusion. And if that's present in the sputum, they are positive for Mycobacterium. It's very easily transmitted through droplets, as other respiratory infections are. And you might be more susceptible to developing tuberculosis if you have any of these things going on with your body. We have our PPD skin test, we have the acid-fast test, we have X-rays as well as PCR and immunoglobulin tests to test for tuberculosis. Active tuberculosis, if you're having the symptoms, the first 2 months you'll be treated with rifampin, isoniazid, ethambutol, and pyrazinamide. All of these are antibiotics that are pretty specific to our acid-fast bacteria. You'll be on that for the first 2 months, and then whichever one works the best, you'll go on for the next 4 to 7 months. So we're talking about 6 to 9 months of treatment with antibiotics in order to clear this bacteria. How many people do you know that would actually adhere to that regimen daily? Right, this is impossible. And so this has led to the development of multi-drug resistant tuberculosis and extensively drug-resistant tuberculosis throughout the world. Moving on to pneumonia, this is a syndrome again that is defined by inflammation inside the lungs. And then fluid will fill the alveoli, making it hard for oxygen to get into the alveoli for the oxygen exchange and carbon dioxide exchange. And so we aren't able to oxygenate well. And that is the effect that pneumonia will give. Viral pneumonia is usually milder than bacterial pneumonia. Usually start off with an upper respiratory infection that will then lead to the lower respiratory expression of the signs and symptoms. Again, discolored sputum, fluid filling the lungs, and things like that are going to be the effect of this inflammation in the lung tissue. And then that exudate, that fluid, will basically allow the bacteria to multiply even more and block the exchange of oxygen and carbon dioxide in the alveoli. The most common cause of bacterial pneumonia is going to be Streptococcus pneumonia. It is community acquired, which means it is transmissible between people. Again, we've talked about Streptococcus pneumonia before. It's gram positive. It's a coccus. It appears in chains and in pairs. And it is alpha hemolytic. So we will have a greening. So here we have this green halo around this guy. If you have a true clearing around there, then that is the beta version. But that alpha will have that green color around it. Again, it is airborne. It's exchanged through air droplets, but you can also have it as part of your normal biome. And then just due to maybe a cold or something like that, now it's able to move into your lower respiratory tract due to the inflammation caused by the other infection. It does have a polysaccharide coating, a capsule that prevents phagocytosis. It also is able to block the effects of complement as a result of having that. We usually treat this with antibiotics, but it has become increasingly resistant to things that we normally would reach for. So we're having to be creative with that. Pneumonia can also be caused by Mycoplasma pneumoniae. Mycoplasma, not Mycobacterium, Mycoplasma. These are the guys that don't have a cell wall. So these guys are pleomorphic bacteria, so they're irregularly shaped. This is what causes walking pneumonia. So these are people that have pneumonia and fluid in their lungs, but are still able to function otherwise. They'll be sick, but they're not going to be bedridden from the lack of oxygenation that's going on. Not to say this doesn't cause pneumonia, because it is still a true pneumonia from the fluid in the lungs, but the presentation of this disease allows you to continue functioning. You'll still be sick, but you won't be bedridden from this. Legionella pneumophila is another bacteria that can cause pneumonia. It's usually associated with bacteria that grow in water environments. And so this is bacteria that would get populated in like cooling towers of, larger buildings that have cooling towers for air conditioning. Do you have a question?
That's Legionnaire's disease?
Yes, that's Legionnaire's disease. And so what it was discovered at an American Legion convention in 1976. Some old guys went to a convention as Legionnaires, a sort of a veterinary, I don't mean veterinary, veterans gathering. So the veterans gathered as part of the Legionnaires convention, and a lot of guys, the older guys, they end up getting sick with pneumonia afterwards, and it was attributed to this bacteria, Legionella pneumophila. And so that's Legionnaire's disease, also known as sick building syndrome. So the building is carrying, because the building is contaminated with bacteria, and now people get sick as a result of that. There's a lot of things that are associated with that, but this is just one of them. Again, it's not super common, and it is usually associated with water. Histoplasma capsulatum. This is also known as Ohio Valley fever, or Darling's disease, or Spelunker's disease. This is more commonly associated with people who have AIDS or people with weakened immune systems. We see this in the elderly quite frequently as a cause of disease. It causes symptoms that can progress to be similar to tuberculosis. It is endemic to a lot of different places. Next is pneumocystis gyrovecii. This guy, again, associated with pneumonia, usually in people with HIV. This is a fungus that will multiply intracellularly, so inside of the cells. Again, usually associated with AIDS.
And how do they get that fungus?
It's just in the environment. Yeah. It's normally in the environment. Then we have a healthcare associated pneumonia that's usually associated with other bacteria, but it's due to people being put on ventilators, that these bacteria that normally would be cleared by the immune system is now being kept in the fluids in the lungs because people aren't able to ambulate and have movement of their lymphatic system to help with the decrease of these diseases. So when you do have about 1% of people who are put on a ventilator or put on respiratory equipment in the hospital, about 1% of them will develop pneumonia. If you develop pneumonia in the hospital, it's a 30 to 50% mortality rate. This is with treatment. So this is a serious issue with hospital-associated infections.
So the problem is that they're not breathing out.
Yes, and so if your patient is conscious, having them sit up, having them cough, having them take deep breaths to oxygenate will help. If they're not conscious, you're limited and you're more likely to have the patients have those effects. It's a big issue, but yes, so having them so here's some things that can help with preventing that and maintaining, of course, clean respiration equipment. But if you've worked in a hospital and you've been dealing with this, then you have an idea of that's next to impossible to do. So it can be an issue. Hantavirus pulmonary syndrome is a viral infection caused by a Bunya virus that is transmitted in the urine and feces of mice. It's usually associated in the Southwest. It does have a mortality rate of 33% when you do have the pulmonary syndrome developing from this. So people will sweep up around their house, the dust from the urine and feces, they breathe it in, and then can develop this. It is also a possible cause of a hemorrhagic fever as well. We're not gonna get into too much detail because I want to move on. All right, that's it. So that's it for today. And then today we're gonna go up to the lab next and do a review for the lab stuff. So I'll see you guys up there. I'm not gonna go over these questions. Remember, you can go through them on your own. They're pretty straightforward, but if you have any questions, you can always email me. And I'll see if I can find my note pages for you guys for the lab so you can see what I'm talking about with like the notes that I make.